Hello, everyone, and thanks for joining us today for the third Blue Alliance Value-Based Care webinar. My name is Jason Lotzer. I'd like to welcome you all on behalf of Blue Cross Blue Shield of North Dakota. A few housekeeping items before we get started. Everybody will be on mute during the webinar, but if you'll be able to ask questions at any time. So if you look at the GoToWebinar panel, you'll see a tab there that says questions, and you can just type them in, and then we'll filter them as they come in. And we'll try to answer as many as possible as we go through today's content. Just to note that we'll only be answering questions related to the agenda topics we're covering today. So we encourage you to ask as many as possible as we go through this. For today's agenda, we're going to be covering nationwide emphasis on value-based care, avoiding emergency room costs and hospital admissions, information reports and reporting enhancements that we've included, expected calculation, the 2020 payment timeline, and then at the end we'll have time for questions and answers. So again, I encourage you to ask as many as possible as we go through this. We'll move on here to who's going to be presenting content today. We have Angel Evenson, Provider Relations Partner. Dr. Greg Glasner, who is our Chief Medical Officer, and Chelsea Matter, who's the Director of Provider Engagement. With that, I'm going to pass it along to Angel to get us started. Are you there, Angel?
I am, thank you. Value-based care is a delivery model of healthcare where providers are rewarded based on the quality of care that they and their teams are providing their patients. Due to the ability for this delivery model to drive down healthcare costs, there has been a nationwide emphasis over the past 12 years. Next slide, please. Blue Cross Blue Shield of North Dakota and other Blue plans work together to deliver a comprehensive network of value-based programs. Blue Cross Blue Shield of North Dakota's program is BlueAlliance. We are proud to be a part of this nationwide effort that has resulted in reducing overall cost trend by 35% since 2016. Though what we are most proud of locally is that 90% of North Dakota members have access to providers that deliver value-based care. Next slide, please. At Blue Cross Blue Shield of North Dakota, we introduced our first program in 2008 and have built upon each program since. As we move forward, we have taken into account feedback from you and providers. Unlike fee-for-service programs, value-based delivery models like BlueAlliance drive down healthcare costs. This is accomplished in multiple ways, including empowering providers with data to encourage providing better care to their patients, and then rewarding them to do so. At Blue Cross Blue Shield of North Dakota, we are committed to providing value-based care through BlueAlliance, where we are focusing on quality care and a fundamental change in healthcare financing. As mentioned previously, BlueAlliance is always evolving, and it is evolving based on the feedback from you. We are focused on two main areas as we move forward. First, communication, building upon the things that we are doing today and making sure that we are communicating as openly as possible. And we are also continually enhancing BlueAlliance through quality accountability with providers and improved reporting for our clients. BlueAlliance results are obvious when you look at these statistics. But even more than these statistics are the stories that we have the privilege of hearing through our provider relationships. Stories such as this. A gentleman came into a clinic because he had cut his hand on the job. The provider screened for depression because BlueAlliance recommends that they do so. They ended up finding out that he was suicidal. That day, they were able to get him the help that he needed. Implementing quality measures as simple as this have impacted more lives than we can count. Dr. Greg Glasner will now expand on the provider's perspective of our BlueAlliance delivery model. Dr. Greg?
Good morning, and thanks for having me. I love doing these webinars. It gives us a chance to talk about the value-based care model, and the BlueAlliance program fits right in with that. And we're continuing to evolve that program, and we're going to continue to invest in this because it is the future, value-based care. People want to know, our members want to know what they're actually getting for the premiums they're paying, and we want to give them value. But more than that, we want to give them better health outcomes. I'm an OBGYN. I've been OBGYN in the state for 25 years, and I'm focused on women's health, and very tangible, very measurable ways you can improve their health is by doing simple screening tests like mammograms and colonoscopies. And if you can pick up a breast cancer early because you did the screening test, then you can improve that member's life and give them a life. If you don't do the screening, if you just come in and do a visit and you talk about a couple problems and they leave, well, then you don't address the chronic or just the basic health surveillance issues. You can miss those. I think of it this way sometimes. A colonoscopy costs $2,500 roughly. Well, if you get a colon cancer, it's going to cost you $250,000 at least, plus all the life disruption of going through treatment of colon cancer, the chemotherapy, the surgery, the life impact on the stress of that. So from a provider perspective, the BlueAlliance programs allows us to measure what we don't know and then focus our efforts on areas that we can improve people's health on. And it's not just from an OB/GYN, it's from everybody. The well-child areas get a strong focus in this BlueAlliance program because if we can keep children healthy from the start and give them a better start in life, their health is better and their care costs less down the road. So I think you're going to see a big focus in the future on vaccines because people are getting a little vaccine shy, but vaccines work and they do decrease morbidity and mortality. So there's great opportunity for us to continue to drive the BlueAlliance program, the value-based program for the members because it not only decreases costs, but it improves outcomes. So next slide, please. So avoiding ER costs, this is one of the big areas we're trying to work on in the BlueAlliance program. The ER is probably the highest cost visit you can have. And if you really think about it, the emergency room visits, most of them aren't emergency room visits. I think the larger systems in the large cities have done a good job of adding in walk-in clinics and urgent cares. And the reality is the small rural sites don't have that option. They'll have a clinic and they'll have a provider or two, and then they have their hospital and emergency room. So we understand that, we get that. People still need access to care, but where there is the resources by using telehealth is a great example. If the members can access telehealth and not go to the emergency room, they can get the care they need that will almost always result in a follow-up with their primary care visit, but it doesn't result in that high-cost emergency room visit. So if we can avoid those high costs, that benefits everybody because it comes back in your premiums. And then most people just don't know. A very common thing I remember when I was a resident and a physician is that people would wait till 11 o'clock and they get tired and they're sick. They don't know, they don't know what to do. Well, if they just jump on a telehealth call, you can avoid having to run into the emergency room, being seen by a provider, have lab tests drawn and an exam, and then almost always they send you home to follow up with your primary care. And it's a huge cost and you really didn't get that much out of it. So if we can use telehealth or walk-in clinics or e-visits, and we can cut those costs down, it's better for everybody. And so you don't have to go sit in the emergency room, you don't have to be around a bunch of real sick people, and you're gonna get the care you need just from a telehealth visit. I get it, there's limitations to all that, but what we need to do is really to work on what is the right level of care and what's the right appropriate venue for that care at the best value for our members. And we're gonna continue to drive that through the BlueAlliance program. So with that, I could talk all day on this, by the way, but I'm going to switch it over to Chelsea now so she can walk you through some of the specifics.
And I can verify that he can talk all day on that. So thanks, Dr. Greg. All right, so let's jump into a little bit of the reporting aspects of what we've been able to deliver to you all, and I appreciate the discussions that we have been able to have with many of you one-on-one, because it's given us ideas for how to enhance the reporting. So thinking about what Dr. Glassner just talked about with the avoidable ER visits and things of that nature, we do try and incorporate those types of things into your reporting so you have some visibility into that. So I'm going to walk through some of the things that we've had in the reporting that you all should have received by now. I'm going to go through a couple of those things and then just highlight some areas that we got feedback on that we're going to be enhancing here as we move forward. So next slide, please. All right, so one of the things that we show is just the membership distribution. So this would be specific to your employer group on your report. It shows how many are attributed to a BlueAlliance provider versus those that are not part of BlueAlliance. And then we have this orange bucket, which is the unattributed members. Those are folks without a primary care provider. And so we show this distribution because there's a lot of breakouts that we show throughout the report that give you a comparison. We know that it's really important to have a primary care provider, and it's proving out again and again through the data. So we like to show you this view so that you can see that comparison as we move through the various components of the report. We also show you the quality performance of the various providers. And so it's important to know, where your folks are going and then where the dollars that you're paying in are going as well. So we've been showing you the breakout between care management as well as any shared savings that the providers have earned. And this is a spot where we think we need to make a few enhancements based on the feedback that we received from you all. So we're showing you how much money is going to the provider. There's a flip side to this. Because there's a shared savings pool of which we're paying out a portion of those dollars to the providers. And so we think it will be important as we move forward to show you what the dollar amount that you as an employer saved alongside of that. So that will be one of the enhancements that will be coming as well. We also on the report showed you an estimated net savings. We gave you kind of the total per attributed member per month piece. And just showed that again. We also showed you a map so you could see the distribution of your attributed membership. I think we'll be making some enhancements to this map so that you have a better idea of where your folks are at in relation to those that don't have a primary care provider. So you can have some visibility into that. So thinking about like a percentage of those within your population within each county, how many are attributed, so that you can see, 50% of my people are attributed in Burleigh County, but only 10% in Stutzman or something related to that. I think that might be a little bit more helpful in trying for us, but also for you in thinking about access to a primary care provider and maybe where you want to focus. I know many of you do a lot of educational efforts to your employees, so it might help kind of target any information that we can supply you or that you have on the importance of that primary care provider relationship. So on the next slide, we also share some health segment information. This is something that we can continue to build on. I know as we were walking through this one-on-one with many of you, we talked about the unattributed population. Again, these are the folks without a primary care provider, so it's always concerning when you see folks with chronic diseases in the mix here. And so we talked about, the things that we can do to help encourage a primary care provider. So just like what we talked about on the previous slide, we can kind of pinpoint that, especially if you have a higher rate or higher number of people that are falling outside of that healthy or non-user category that we see, so that it's certainly important for those healthy folks to have a primary care provider as well. But, want to make sure that if you have a higher rate with folks that have chronic disease that don't have that primary care provider, that we're we're trying to emphasize the importance there and get those folks in to establish care with someone, but also wrapping around our care coordination services at Blue Cross and having our care coordination team take a look at those folks and try and understand, is there something that we can do to encourage that? Can they benefit from a case manager, that type of thing? So we'll continue to show this because we think it's important to review on a regular basis as well.
And Chelsea, we had a question come in here. If you have
sure.
Yep. They had just said that they hadn't received this info that they're speaking of, and basically, how do we get a report on a group? If somebody hasn't received a report, how would they go about getting one from you guys?
Sure. I believe they should reach out to their account representative to receive that report. Is that right, Chris or Dorinda? I think that's probably the easiest.
This is Dorinda. Yes, that is correct.
Perfect. Thanks, Dorinda.
Perfect. And we had one more question on this slide, Chelsea. As you see the bar charts here, we asked, what is stable? What does that indicate versus healthy?
Oh, good question. So these different health segments, so when I think about stable versus healthy, I think of somebody that may have an underlying condition, but is, in a stable state, meaning that they're not utilizing the ER frequently, that type of thing. So healthy, I think of as, not having any acute conditions, and stable, you might have an acute condition or you've had some, but you appear to be fairly stable. And I can get more information. That's my non-technical answer. There's a lot of logic behind this. We actually utilize 3M. So the Post-it note company also does a lot within data analytics and healthcare. And so we can get a little bit more information related to that. But that's my non-technical answer for today, is they might have some type of underlying conditions, but they appear to be stable based on what we see from their utilization pattern.
And then the last question that we had on this was, who is in each of the groups, the BlueAlliance, the PCP, and the unattributed?
Oh, sure. Yeah, great question. So this is a snapshot of your employees. So those that have a primary care provider that's part of BlueAlliance, this is showing the distribution of those members. And so you may have, 20 members that have a primary care provider in BlueAlliance, and then we show you what the distribution looks like. So if they're at risk, complex, chronic, that type of thing. And then there's also, the vast majority of primary care providers are in a BlueAlliance program, but we do have some that are not in BlueAlliance. And so that's that green section. So these are folks that have a primary care provider, but that primary care provider has not engaged with us on BlueAlliance. So it's kind of that in between phase. So we're happy that they have a primary care provider, but we hope, that primary care provider will join us on this BlueAlliance journey at some point. There's very few folks or primary care providers that are not in BlueAlliance, but we do have a few. So that's the green. And then the unattributed are those employees of yours that do not have a primary care provider, and then the distribution of what bucket, if you will, they fall into from a health standpoint. So hopefully that helps.
Yeah, thanks, Chelsea. I think we can move on now.
Okay, perfect. On the next slide, we are showing you an inpatient and ER visit utilization. So much like Dr. Glasner was talking about ER visits, this is one of the reasons that we like to look at it in these three different breakouts. So you can see that those that have a primary care provider that's part of the BlueAlliance program, they tend to do better in these metrics. And so the more negative the number, the better. So what this is showing you is inpatient admissions per 1,000 per year. And this is a variance from expected. So what that means is that inpatient admissions, they were admitted to the hospital 18% less than we would have expected given the illness burden of the population. So typically what we see, and this is going to vary by group, your group size, if you have a smaller group, there's going to be a little bit more variation here. But typically what we see is the BlueAlliance folks do better than those that are have a primary care but are not in BlueAlliance, and do better than the unattributed population. In a lot of the reports that I've looked at, that actually the orange bar, that unattributed bucket usually is above expected. It's not in the screenshot that we grabbed here, but a lot of cases, what we're seeing is folks that don't have a primary care provider are utilizing the ER or being admitted at a higher rate than we would have expected given the illness burden of that patient. So a great story to be told here, and it again just highlights the very important to have a primary care provider. And I mentioned before, it keeps panning out in all the data that we look at. And so this is something that we can provide you that's in the report that's specific to your population. But just keep in mind, the smaller the population, the little bit more variability there is. So we don't always see it end up like this. But typically we've seen improvements over time. And again, kind of one of those things of why we want those unattributed folks to get hooked up with a primary care provider, so we can turn them into that blue bar, part of that blue bar. So, all right. So I've already touched on these two items as we were going through the screenshots of the report. So just again, we want to add some enhancements to the map to show you your percentage of members or employees that are attributed to a primary care provider by county. So that help inform any educational efforts. We also want to look at that ourselves as a plan, because that can help inform some of the campaigns that we may want to do in those communities as well. And then the specific employer group shared savings piece. So in addition to that per attributed member per month, showing you, the shared savings that goes to the provider versus the shared savings that you keep. So those are two of the main enhancements that we're making to the report based on all the great feedback that we've gotten from you all. And so I, again, very much appreciate every conversation that we've been able to have. It helps us build a better report for you and show the value that you've been hearing about throughout the presentation. So next slide. So let's talk a little bit about the financing aspect. So we just ran through the report. We're going to touch a little bit more on the financing piece. And some of these slides, if you attended our other webinars, are going to be familiar to you. I think it's important to keep running through this. We've continued to get some questions about kind of how the calculation works. And so I just want to take this time to go through it a little bit more to hopefully provide some clarity here. Next
And Chelsea,
slide.
I had two follow-up questions that were on the reporting parts of it. I thought we'd get those right away here.
Yep. Perfect.
One was, how recent data can we get access to when it comes to the reports?
It's a good question. So some pieces of the report we would be we can get as we update that information every month. There's some aspects of the report, and so the dollar distribution, so shared savings doesn't get distributed as often as the care management piece does. So that piece might have to change, but most of the other information within the report is available on a monthly basis. I think we had originally planned on doing this quarterly, but if folks want to see more recent data, we can work on making a monthly report available as well.
Great, thanks. And we had one other one here that might be a little more specific. I'm not sure you can answer, but they asked when we'll be able to see data for our employees that are Minnesota residents.
Oh, good question. So one of the reasons that, and I should have mentioned this, we isolate the report to North Dakota residents because there are, when you start to bring in folks from Minnesota, which, Clay County and the contiguous counties is fine. So we can certainly bring in folks from there. Once we get further out, the noise or the data gets a little bit noisy because they may be doctoring and part of a value-based program in another state, in which the other state has different parameters related to their value-based program. So we were trying to really show you what it means from a BlueAlliance perspective, but those folks may, the further you go out from North Dakota, they may look like they're falling into the unattributed bucket, but they in fact do have a primary care provider that just happens to be associated with another value-based program, so it introduces a little bit of noise. But as far as the contiguous counties, so Clay County, East Grand Forks County, all around, we can certainly add those folks in if you have large amounts of folks that reside in those counties. So we can certainly work with you to make that happen too.
Great, thanks,
just
Chelsea.
a nuance in our data. Okay, perfect. All right, so wanted to cover in two main payments that are associated with BlueAlliance. So we have the care management payments, and we have shared savings. So care management, again, supports care coordination efforts, and this is payable to providers in all levels of the program. So providers can elect to be in different risk arrangements with us as part of BlueAlliance. So we have some providers that only receive care management payments. So some of you may have noticed on the reports that you received that when you look at the shared savings column, there's zeros. Some of those folks just are not part of that shared savings arrangement. There's be a couple of different reasons for that. Typically, it's because they don't have enough patient volume. So in order to make a shared savings arrangement viable, you need to have a large pool of folks. Otherwise, there's a lot of variability and it's hard to measure shared savings. So care management is payable throughout all the levels. It is adjusted for the provider's quality rating. So if they are not hitting the quality mark, meaning that they're not doing well on the well-child visits or they haven't seen improvement there, the potentially preventable ER visits or hospital admissions, we measure them on those types of things. The story that Angel covered with the depression screening, there's points attached to those. So if they're not screening for depression and doing some of those things, then the care management payment is going to be less because we think those things are very important. And so that's one component, and then the shared savings, which we'll get into here in a little bit. So next slide, please. Do you want to share as we move into, well, we're well into 2020 now, and I'm sure some of us want it to be 2021 already. But for care management payments, we are doing monthly payments related to that. We had a little bit of a pause as we went through trying to finish up 2019 payments and rolling into 2020. But I'll share at the end here the payment schedule related to that. But we've been doing monthly care management payments. Again, this is meant to be, more frequent and more predictable for you all. So having done in the years leading up to this back to 2008, we always did payment distributions 2 times a year. And so depending on how well the providers did, you can see a fairly large dollar amount go out the door 2 times a year. So we're trying to make that adjustment so that it's more predictable for you. So care management payments are also risk adjusted. So we have this estimated average care management per member per month. I will say that's the average that we see depending on the health of that member. So we know if you have multiple chronic diseases, it takes a little bit more to coordinate your care. And so those folks will pay more in care management, provided the provider does well on the quality front. But there's this matrix, if you will, of how the illness burden of that patient and how well the provider has done from an overall quality perspective. And so the the better the quality that provider is providing, and the riskier the patient, the higher the dollar amount is going to be. But we also have the opposite end of the spectrum, where folks that are healthy or non-users or whatever the case may be, they don't take as much resource use from the provider community, so we're going to pay less on them. Still important to coordinate their care and make sure that they, get their appropriate screenings and things of that nature, but just not as resource intensive as the others. And so just know that there's a range there, but this is the average. And then we started those payments in September, and they actually go, I think that we have a typo on the side, but they actually go through February or March of 2021. So that's the care management piece. And then shared savings, we have historically done that twice per year. We're looking to do possibly quarterly. There's some COVID implications there, but we're estimated to deliver the first interim payment in November. But again, COVID at the beginning of the year has definitely impacted utilization overall. So we're trying to be conservative with our projections there. Okay. All right, next slide. So I think this one is important to share. I know we've shared it a couple of different times. I want to emphasize that the shared savings model in the Blue, that we've developed within BlueAlliance, I would not think about it as new money. So historically, when you live in a fee-for-service world, you provide an increase to that fee schedule, which incentivizes the volume of care, not necessarily the outcomes or the quality of that care. And so what we're doing is we're slowing down the rate of increase for that fee-for-service world, and we're shifting those dollars into that shared savings bucket, which the providers have to earn based on good outcomes. And so I just want to emphasize this a couple of times, that it's not new money, it's shifting of how we pay for healthcare from something that's volume driven to something that they need to earn based on good patient outcomes. Next slide. All right, so if you watched the other webinars, you've seen this illustration a couple of times. So my apologies if this is, you got it. I'm going to run through this, again today, because we have gotten a few questions. So in this particular example, we have a provider that has 20,000 members. So these members are across, multiple employer groups, but they all belong to provider X. And so when we look at those 20,000 members, we develop, or in coordination with 3M, they come up with an estimated cost target. So those 20,000 members have different degrees of risk associated with them. They also have historical utilization patterns. So how much did it cost to take care of these folks last year? And then what do we, what kind of risk were they at last year, utilization, all of that. And then as we move along through the new year, if that risk changes, that expected cost target also changes. So if you have a bunch of sick folks that start to get better, this expected cost target is going to get lower, because we know that it takes less resources to take care of a more healthy population, and vice versa. If you have a bunch of healthy people that start to get sicker, this cost target is going to adjust to reflect that. So each month we look at that expected cost target versus actual cost. And so if their actual cost is below what we expected, given the illness burden of that population, that is going to generate what we call the savings pool in step number 3, so expected minus actual. And then at different points, so whether it's quarterly or twice a year, we'll take a look at this performance, and then we'll distribute the dollars related to that. So providers can earn that shared savings. First of all, they have to have a lower actual cost than expected, but then they also have to have hit the quality metrics. If they are didn't get all the quality points to say, their well child visits are going backwards, or they're not keeping people out of the hospital as well as they should have, that type of thing, and should have, maybe is the wrong phrase to use there, but for whatever reason, folks are using the hospital or the ER more than we would have expected. That impacts the amount that they get to keep from that shared savings pool. So what we don't want to have happen is folks kind of drive down utilization while compromising quality. So we have to have that quality check to say, okay, you achieved savings, but you also maintain good quality. So this is the portion that we're going to share back with you. So that's that, up to 40% in this particular example. And so you see the $1,890 is what we would pay to the provider, but that rest of that savings pool is pretty much what if that pool is what would have happened absent of the BlueAlliance program. So our thought is, if their BlueAlliance program did not exist, that population would have costed $534 per attributed member per month, but they didn't. So we're sharing a portion of that back. So hopefully that helps explain a little bit more. I know I've had lots of questions on this one. More than happy to do additional one-on-one conversations with you all to make sure that folks understand kind of how we're arriving at this. So we also shared the timeline with you, so you should have received this. And so I was mentioning the care management one. And so care management started in September, and you can see it goes through March 3rd of 2021. So you should have received this. As I mentioned, we're expecting the first shared savings piece to go out in November, which you would be billed in December, and then some additional payments into 2021 for 2022. So, and wanted to make this more predictable, give you a schedule so you knew what to expect moving forward here, and that we're all on the same page with what's happening and when. So I think that is the last slide that I had. Other than we've talked through a lot of different next steps. So reporting will be an important component of it, and making enhancements there. So I appreciate the question earlier about frequency and adding some Minnesota residents, that type of thing. Certainly can look at making those enhancements in addition to the ones that we talked about. And then just keeping up with the payment schedule and making sure if there's any changes to that we keep you informed. But so far, I think it's been going smoothly. You should all be receiving information related to those payments as well. And so if you're having any issues with reviewing that information and wanting further detail, we can certainly talk about that as well. So I will stop there and we can open it up for Q&A. Any more questions, Jason?
Yeah, there was a couple here, Chelsea. One of them that came in, it was probably related to just a couple slides ago, is that 40/60% an example of the actual division of shared savings between provider and employer?
Yes, that is an example. So there's two different participation levels when it comes to shared savings. And so one, they can earn up to 40%, and the other, at least in the previous time frame, you could earn up to 60%. I believe we moved that to 65% for this new arrangement, but it will vary depending on the quality. So you may see some folks that achieve, 50% of the 40%, if that makes sense. That type of thing. And if they completely miss the quality mark, then they don't get any shared savings. But you can see anywhere from 0% up to 65% going to the provider, but that's dependent on their performance.
Perfect. Thanks, Chelsea. And we had another one come in here, Chelsea, for you. When do we get to see statements showing the net impact to each customer group?
Net impact to each customer group. So related to the shared savings piece, I might need to follow up on that one just to make sure I understand the question.
Yep, and we do have this person's name, so we can definitely get back to them with some more details.
Perfect.
So Dorinda, I have a couple questions here for you. Are you there, Dorinda?
Yes, I am.
Hello. So one is, how can we identify care management or shared savings charges on invoices?
Okay, thank you. So as Chelsea just showed you, we did first provide a calendar for BlueAlliance 2.0, which kind of gives you the when these charges will be showing up. BlueAlliance claims charges show up on your weekly invoices. You can find them in two places on eBill. The first place is the paid claims expense summary. So where value-based claims or reimbursements used to show up in the paid claims column, they now show in their own separate column that is labeled value-based reimbursements and are included in the total paid claims and expenses column of that part of eBill. Then there is another tab in eBill that is called value-based reimbursement detail. And that is where, if you want to drill down to the member level, that you can get to that member level detail.
Great, Dorinda. I have another one I think that would be good for you here, Dorinda. What type of support do you offer in order for us to engage employees around this program?
Well, at Blue Cross of North Dakota, we have many ways to engage employees in their own health and wellness with our Healthy Blue Wellness Program and member education, such as for the member ed programs, the 6 keys, getting the most out of your health plan, which happens to have a component that focuses on the value of having a primary care physician and getting preventive services. That is all provided from our wellness and member education team. Then there's also open enrollment presentation support and health or wellness fair support. As always, we encourage all of our members to speak up to be their own advocate when engaging with their doctors, nurse practitioners, or other clinical staff, as we believe the better we all communicate with providers, the more inclusive our care will be. BlueAlliance, however, is a provider-based reimbursement program. So that means that the providers are responsible for their own performance. You've kind of heard Chelsea talk about that throughout the presentation. They're responsible for their performance as it relates to quality and managing patients to be receiving the right care at the right time in the right setting. And provider engagement, we just want to make sure that you are aware that the provider engagement and overall responsibility to make this program successful does rely on the provider.
Great, thanks, Dorinda. Chelsea, I have another question here for you. When can we expect payments moving forward?
Sure, good question. So certainly reference the payment schedule that you all have been sent. That's I think we've been keeping to that schedule so far. So that should be a good roadmap as we move forward. And then, as I mentioned, the shared savings piece is below that. So if you go back actually to slide, I think 25, Jason, that's what I'm referring to. And you all should have received an email that outlines this. So care management is on the top, and the shared savings pieces are on the bottom. And then if there's any changes to this particular plan, we'll be sure to communicate that with you all.
Great, thanks, Chelsea. Chelsea, I think you can take this one as well. Can the care management and shared services charge be labeled as such directly on the main invoices instead of labeled additional or other charges?
Ooh, I might toss that one to Dorinda or Chris. I'm not sure that we have flexibility in changing the name of it, but certainly something that we could look at. I don't know, Dorinda or Chris, if you have any thoughts on that one.
This is Dorinda. I can answer that one. Right now, as I said before, it's under the value-based reimbursement column. So you at least know that it's either care management or shared savings. There is enhancements planned to try to get that broken out so it could say one or the other, but that is not something that will show up in that manner as of yet. So just expect it to be where it says value-based reimbursement.
Okay. Well, I think we're to the end of questions here, guys. So I'd like to thank everybody for participating today. Again, I think there's some enhancements that are going to be coming, as Chelsea spoke of, and we encourage any feedback that you guys would like to provide. So thanks again for joining us today, and have a great afternoon. And thanks to all the presenters for sharing this content today. It was great.
Thank you.